Okay, good afternoon. Am I audible? Audible? No? Okay, now audible? Yeah, thank you. Yeah. So how do I optimize volume status in ARDS? Again, the display has changed, so some of the slides may come out wrong. If it does, I apologize. Okay. So first, before I optimize the volume status, I need to know what is optimum fluid balance in a patient. I'm going to talk only about a patient with ARDS. So I need to understand the physiological changes. I need to understand the interaction between the mechanical ventilation and the cardiovascular system a little bit more. Then define my goals of volume management. Then I need to see what tools I have to achieve those goals and whether those tools can be used in ARDS versus a non-ARDS patient, and then we'll come up with some kind of a conclusion. So that's kind of the flow I'm just going to take through the next 20 minutes. So you heard a lot about ARDS management in terms of gas exchange, in terms of ventilator-induced lung injury. I see ARDS as managing the tissue perfusion, making sure all the tissues are happy, making sure I have adequate gas exchange, and also making sure that I ventilate in a way that I do not do more harm than actually doing good. So all these three I need to be careful when I manage a patient with ARDS. Obviously, when I talk about tissue perfusion, I need to know what volume status is and whether I have optimized the volume status, and that is where this talk becomes very important. But I will also argue that volume status becomes very important because if I give too much fluid and cause pulmonary overload, I am going to interfere with gas exchange, and that is going to be a problem. And what I will argue is volume status also will determine and contribute to ventilator-induced lung injury. Two drier lungs will contribute to ventilator-induced lung injury, two wetter lungs will contribute to ventilator-induced lung injury, and I will go through some of the mechanisms of that. What are my concerns about volume when I treat a patient with ARDS? On one end, I have increased capillary permeability across all the pulmonary vasculature. Because of that, I have increased pulmonary edema that happens, and that in essence causes decreased compliance, which means I need to use higher and higher pressures to keep the lungs open, and you have just heard about what higher driving pressures can do to the lungs in terms of ventilator-induced lung injury. You have an alveoli filled with fluid essentially working as a significant shunt, and therefore you cause hypoxemia. That can be a problem. And the accumulation of the alveolar fluid varies depending on various factors, regional and gravitational factors, that the lung becomes more heterogeneous because of pulmonary edema, and that in turn causes more ventilator-induced lung injury. Pulmonary hypertension can be caused both by increasing shunt and increasing dead space that can happen in these patients, and I have increased pulmonary vascular resistance, and all of this in some extent are going to cause right ventricular failure and acute cor pulmonale in patients with ARDS. On the other hand, I have ARDS patients who have significant hemodynamic instability and are shocky, who need some kind of an optimization in terms of the volume status. This could be contributed by either relative or absolute hypovolemia. There is a significant component of vasodilatation that happens in septic patients with ARDS. There can be a significant component of LV dysfunction that happens in sepsis in ARDS, and as I mentioned before, you can have acute RV dysfunction and acute cor pulmonale, all of which in various proportions can contribute to impact tissue perfusion and shock that happens in ARDS. So my goal in ARDS in terms of volume assessment is going to be determining if I give volume, will my cardiac output go up? Here you have a patient's Frankstarling curve. If I give volume and increase the preload from here to here, you can see that I have a large increase in cardiac output. This is the extravascular lung water curve. At the same time, I am not increasing the extravascular lung water significantly at this part of the curve, versus if the patient happens to be in this part of the curve, I give volume, the cardiac output does not go up, but you can see that my extravascular lung water goes up significantly, and therefore I can do potential harm with the same aliquot of volume that I give depending on which curve the patient is at that point of time. So ideally, if I am going to give volume to a patient with ARDS, I want to increase at least the stroke volume without increasing the extravascular lung water as a basic minimum, and this is what we are trying to do. But what we need to understand is, in ARDS patients, as the permeability increases, this is a person who's got a normal capillary permeability, I give volume, you can see that my extravascular lung water does not go up significantly. As my capillaries increase, have increased permeability, in this graph here for the same amount of volume, you can see that my extravascular lung water went up significantly. So not only depends on what my Frankstarling curves look like, it also depends on what my permeability graph looks like and which part of the curve I am in, and even small volumes of what fluid that I give to the patient can cause substantial increases in extravascular lung water in a patient with ARDS. So this is something that has been discussed several times. This is the vascular endothelium, interstitial space, alveolus and the lymphatics. What happens in ARDS is there is fundamentally an increase in capillary permeability as part of the disease. So already the capillaries are leaky, and you heard Dr. Sumitre saying the pores open and the fluid starts going up, both fluid and protein start going outside. Number 2, the hydraulic filtration coefficient, which Dr. Sumitre talked about, also is increased in patients with sepsis in ARDS, as he alluded to. Simultaneously, there is a decrease in albumin levels in hypoalbuminemia, and therefore there is a decrease in the amount of oncotic pressure gradient that happens that tries to keep the fluid inside the vascular space. Number 4, there is increased pulmonary vascular resistance, either from hypoxemia, hypercapnia, or the mechanical ventilator that we use, that is going to squeeze the fluid outside the blood vessel. Once the fluid goes outside the blood vessel into the interstitium, the lymphatics have to drain it back and through the thoracic duct bring it back to the intravascular space. There is a significant component of lymphatic dysfunction that happens in sepsis and ARDS, that mechanism is injured. And finally, once this barrier is breached and fluid enters the alveolus, the normal protective mechanism is there is an active reuptake of fluid outside the alveolus back into the interstitium, and that mechanism is also blunted in patients with ARDS. So in all, there is an increasing tendency towards filtration of fluid across the vascular endothelium into the extravascular space in general in all patients with ARDS, and that is for us fundamentally important to understand. So concept 1, summarizing pulmonary edema in ARDS, the FACT trial showed that more than 30% of the patients with ARDS had a high wedge pressure, more than 18, which by definition would say cardiac pulmonary edema, but you can understand that patients with sepsis are going to have LV dysfunction. So intrinsically, some of the patients with ARDS are going to have a higher hydrostatic pressure than what you and me think would happen. Understand that in the presence of an increased vascular permeability, you can have pulmonary edema happening even with normal hydrostatic pressures, as I showed you in the vascular permeability graphs earlier. Remember that because of all the physiological changes, there is an increased propensity of fluid filtration across the vascular endothelium space, and this is mainly contributed by increased permeability, but also remember that there is ineffective oncotic pressure gradient that tries to keep the fluid inside the vascular space. Once the fluid goes out of the intravascular space, there is a blunted compensatory mechanism in terms of decreased lymphatic function and decreased alveolar reuptake, so fluid that gets out stays out longer. And remember that this pulmonary edema causes significant worsening of gas exchange. It causes vascular and lung injury. Pulmonary edema depletes the surfactant, washes away the surfactant, and therefore you cause significant amounts of collapse, atelectasis, and then heterogeneity in the lung that can subsequently contribute to both vascular injury and the alveolar injury. The second part of the triad is tissue perfusion ARDS. As we saw earlier, it could be from hypovolemia, vasodilatation, LV dysfunction, and significant amounts of RV dysfunction. RV dysfunction could be from the LV failure, it could be because of increased afterload to the right ventricle, we will talk about the mechanisms in a bit, increased mean airway pressures caused by the ventilator, or it could be because of overzealous fluid administration that you and me do, and that is the part that we are very worried about not to overdo in terms of the fluid administration. So what are the effects of mechanical ventilation on the lungs in ARDS patients? If a patient, we talked about paralyzing a patient, let's say the patient is not paralyzed, he's got spontaneous breaths and there is an increased amount of pleural swings, there is going to be more and more negative pressure breaths that are going to be started. That is going to increase your RV preload, because with every negative pressure the venous return to the right ventricle will go up, so the preload increases. Simultaneously, there is a decrease in LV afterload because of changes in the transmyocardial pressure gradient that happen on the LV. So simultaneously there is more blood going into the RV and into the pulmonary circulation, and at the same time there is decreased LV function because of the afterload increase that happens on the left ventricle, both of which are going to make more blood stay in the pulmonary circulation and increase the pulmonary blood flow. Number 2, I am going to use increasing airway pressures over a period of time that is going to compress on my blood vessels. I am going to cause vascular collapse. This vascular collapse will decrease the amount of capillary reserve I have to accommodate the increased pulmonary volume that is going to happen because of the part 1 of my algorithm, and this also causes a lot of vascular stress, because wherever the alveoli are compressing the vasculature, it causes a waterfall effect, and suddenly pressure there builds up, and then suddenly that causes increased shear stress off the vasculature, and that is going to cause increased pulmonary hypertension over a period of time. If I use undue amount of mean airway pressure, I am going to cause West zone 2, where I am going to press on the blood vessels. This indirectly is going to cause increasing shunt, because the blood is now pushed to alveoli that are not very ventilated. That is going to cause shunt. It is also going to cause some dead space. Both hypoxia and hypercapnia will increase my pulmonary vascular pressures and cause pulmonary hypertension, simultaneously increasing my vascular injury. So on one end, I am increasing my RV preload, putting more blood in the pulmonary circulation, increasing the pulmonary vasculature, decreasing my LV function, and causing significant stress both to the pulmonary endothelium and the alveoli, all of which are going to cause worsening pulmonary edema and significant amounts of right ventricular dysfunction. And this has been very clearly shown in patients with ARDS. 25% of patients with ARDS have acute RV dysfunction and cor pulmonale, making it very important. In one study, they looked at the risk factors of which patients go into right ventricular failure, and they found 4 predictors. If you have a pneumonia as a cause of ARDS, you are more likely to go into right ventricular function. If you have significant hypoxemia with a PaO to FiO2 of less than 150, you are likely to go into acute cor pulmonale. If you use high driving pressures of more than 18, again, and a PaCO2 more than 48, as much as we want to do permissive hypercapnia, it is extremely harmful to the right ventricle, especially if it's failing, and that's something that we need to think of. And if you allow the lung to de-recruit or over-distend, then it's going to be a problem, because either way, either you will cause hypoxemia or hypercapnia and worsen the right ventricular dysfunction. And remember that all this can be made worse by more and more fluid administration, because the RV is struggling. You are pouring more fluid into the RV, the septum is going to bulge, it's going to cause decrease in the left ventricular end diastolic volume, and therefore decrease in the left ventricular output, and ventricular interdependence is going to worsen your shock even more. That's the part 2 of the story. So for assessing tissue perfusion, not only do I have to look at hypovolemia in a patient with ARDS, I also need to be cognizant of the fact that RV will fail. I need to be careful about what the RV is doing before I decide what the best strategy to treat these patients are. In terms of gas exchange, I need to be cognitive of extravascular lung water and the pulmonary edema and the downsides of whatever those two can cause. To summarize, in terms of tissue perfusion, yes, if there is hypovolemia, I need to correct it for sure. But understand that acute right ventricular failure and cor pulmonale is reasonably common in patients with ARDS, can be made worse by volume. Hemodynamic optimization hence must incorporate not only the volume status, but also the function of the right ventricle, and see whether the right ventricle can handle the fluid. And I need to do a risk benefit assessment to say whether my response to volume or harm from it will be the key factor, and then decide my fluid administration or strategy accordingly, and then take it from there. So now, with that kind of an understanding, let me see if I can define my goals of optimizing volume in ARDS. My first question is going to be, is the tissue perfusion adequate, or in other words, is the patient in shock? That's the first question, obviously I need to know. Second question is, if the patient is in shock, is volume loading going to help? For that I need to answer 2 questions. Can the RV take it, and can the LV use it? Can the RV take it? It just tells me how much the RV is failing. Can the LV use it? Is what we call preload responsiveness. Will I do harm giving more fluids? Again, can the RV take it? What will happen to gas exchange? What will happen to my compliance in a patient with ARDS? I need to put all those things together and then make a decision on what volume status I need to maintain for this particular patient. The easiest is patient has no shock. He has got straightforward ARDS, no shock. All of us are easy. Probably we have the best evidence for this in terms of the FACT trial, where they randomized patients who were not in shock, after they were resuscitated very clearly, and then they decided to do a liberal strategy or a conservative strategy in this particular situation. 1,000 patients, they clearly showed that patients who had a conservative or a liberal strategy, there is no difference in mortality, even if you restrict fluids to those patients, but they came off the ventilator faster. The downside, everybody will ask me, is was there more acute kidney injury? The answer is yes, more acute kidney injury, but not necessarily more renal replacement therapy. Yes, their BUN creatinine went up a little bit, but no significant consequences came out of it. So you're not doing terrible harm by doing a conservative strategy if the patient is not on shock based on this particular study. Remember that these patients had a baseline blood pressure of 77 millimeters mercury of a mean arterial pressure. Their cardiac index was 4 liters per minute square, so they were all hyperdynamic. Only 30% needed vasopressors. 30% of these patients, despite all this, had a wedge pressure more than 18. They stopped the diuretics if the patient went into shock. So the key point I want to drive here for the trainees is the conservative fluid strategy is something I would think about definitely only if the patient is not in shock. This study does not apply if for patients who are actually in your ICU with significant vasopressor dependence. So now, what do I do if the patient is in shock? If the patient is in shock, I need to think of three things. Does the patient respond to fluid? Does the patient have RV dysfunction? What is the lung water? I need to be able to assess these three things and then make my decision based on what we have decided earlier. I have various tools to look at all these three things. We'll just quickly go over. We talked about vena cava size. Vena cava size is not a good predictor of fluid responsiveness. It tells you what the CVP is at best. You can look at SVC or IVC distensibility. We are talking about an intubation patient. Sensitivity and specificity are not that great once they are intubated. You have to understand that you need to get a good window. If you have an obese patient, abdominal surgery, a lot of edema in the abdomen, the window can become a problem and technically may not be accurate, especially if a junior is doing it. Remember that even for IVC distensibility, you need a tidal volume of more than 8 ml per kilo, which none of our patients would have, and you need to have lung compliance that is good so that whatever is happening in the lung is transmitted into the IVC. SVC you cannot do that easily because you need a TEE. So you need certain prerequisites for you to be able to look at vena cava size. How about heart-lung interactions, looking at any one of these variables that we have talked about? Remember that in an ARDS patient, there are several things that is going to confound my assessment of pulse pressure variation with whatever gadgets. One, most of the patients will be spontaneously breathing unless we paralyze them. You can have arrhythmias, very common in somebody who's hypoxic and who's got a predominant pulmonary disorder. Most of the patients will have a tidal volume less than 8 ml, again making it void in terms of looking at heart-lung interactions. Lung compliance can be extremely poor, and therefore whatever you do to the chest will not be transmitted into the right ventricle and the left ventricle for you to have significant changes in stroke volume beat to beat to cause changes in cardiac output. Your heart rate to respiratory ratio can be low, especially if the patient is tachypneic, and therefore you do not give enough time for the blood to go from one chamber to the other to see significant changes in cardiac output. You can have increased intra-abdominal pressure or RV afterload dependence, all of which can interfere with the way you interpret your pulse pressure variation in the ICU. If you look at it carefully, more often than not, a lot of these factors will give you a false negative pulse pressure variation test rather than a false positive, so you can just take that into account. I'm just quoting you only one study. There are several studies that looked at what proportion of patients in the ICU are actually fit for me to do a pulse pressure variation, especially looking at all these criteria. In one study, they said only 2% met all criteria, and most studies will tell you that 80% of your patients in ICU will not meet criteria for you to look at pulse pressure variation in an ICU, even in a non-ARDS patient. In an ARDS patient, this essentially becomes extremely small proportion. So most patients are unsuitable by looking at pulse pressure variation, and remember that you'll have a lot of false negatives because of compliance issues and because of tidal volume issues. To overcome the tidal volume issue, this is a study from Tata Memorial, so all of you should know about it. What they did is they took patients who were on 6 ml per kilo tidal volume, they measured some baseline variables in terms of pulse pressure variation, then they gave the patient 8 ml per kilo tidal volume, making sure that the patient is not having a spontaneous breath. They measured all those variables in 8 ml per kilo again. They called it a tidal volume challenge for 1 minute. Then they dropped it back to 6 ml per kilo, allowed the patient to come back to baseline and compared it with patients who, then they gave a fluid bolus to the patient and then looked at the cardiac output after what happened. And they were trying to see if they can predict fluid responders. If you increase your cardiac output by more than 15% after the fluid bolus, you were considered as a responder using a PA catheter. What they found was very, very interesting. They found that neither the pulse pressure variation at 6 ml nor the pulse pressure variation at 8 ml were very, very good predictors. However, a delta, if your pulse pressure variation changes by more than 3.5% between 6 ml and 8 ml, that seems to be a very, very good predictor of fluid responsiveness in a patient with ARDS. So this is one trick you could do if a patient has got 6 ml per kilo tidal volume, to temporarily increase the tidal volume to 8 ml, assess your response and then bring it back to 6 ml. But remember that even for this, the lung has to be compliant. They did 20 patient study, all the 20 patients, the lung compliance was actually more than 30. If you have a lung compliance less than 30, again, increasing your tidal volume will not get transmitted enough for you to change your preload significantly, and that could be a limitation of this technique, but this is one step forward. So can I do a PLR? The answer is yes, you can do a PLR in a patient with ARDS as long as these fallacies are not met. Understand that the patient should be having some amount of preload. If he's extremely hypovolemic, then he's not going to be having significant amounts of change if passive leg raising. Similarly, if they have significant cardiogenic shock, then they are not going to be having pulse pressure variation. You need to be careful. You need a real-time monitoring of preload and a real-time monitoring of an arterial line for you to be able to tell you. Remember that the arterial line derived pulse pressure variation sensitivity is very poor. Ram was talking about it in the morning. So you will more likely end up with a false negative result. If it is a positive result, it most likely means patient is fluid responsive, and then you can interpret it that way. And remember that increased intra-abdominal pressure can interfere with it, and increased sympathetic activity can cause a false positive result sometimes. So you need to be careful about using PLR in those patients. If those criteria are met, you can certainly go ahead and use a PLR. Are there anything else I can do? This is an end expiratory occlusion test. Understand that every time there is a positive pressure breath given to the patient, the venous return decreases because intrathoracic pressure goes up. What you do is you put an end expiratory pause like how you do to measuring autopy. It has to be done at least for 15 seconds, and during those 15 seconds there is no breath. Therefore, slowly the preload increases, and therefore your cardiac output increases, and then you measure your cardiac output 15 seconds after an end expiratory occlusion test and see if the cardiac output goes up by 15%. What they clearly showed is you can use a regular pulse contour analysis cardiac output. You don't need any fancy monitors. If you can get a PICO or one of those pulse contour analysis, then that kind of cardiac output measurement is good. Pulse pressure variation may not be a good marker of fluid responsiveness when you use it. They showed that this is a good test even if you have a low respiratory system compliance and it's completely independent of PEEP. So maybe end expiratory occlusion test is a good test that we can try to employ in patients with ARDS. Coming back to this, okay, after all this I have done an assessment, I have a rough gestalt of whether this patient is fluid responsive or not. Should I give fluid? This is again another study which Dr. Ram quoted in the morning. This is the follow-up of the FACT trial where they looked at the number of patients who got fluid boluses were about 570, and what they did is they looked at the patients and said how many of them actually improved the cardiac output, and what they found is only 23% of the boluses actually resulted in an increase in cardiac output. Other 80% did not have a change in cardiac output at all. That's number one. And it didn't matter. John Louis Vincent typically says is you give fluid, if the CVP goes up by 2, then you have altered the preload. It didn't make a difference whether the CVP went up by more than 2 or did not go up by more than 2. You still didn't see a change in cardiac output. So changes in CVP are not going to be able to predict changes in cardiac output in patients with ARDS, at least based on this trial. And not only that, they looked at the cardiac output is only one thing, and Ram was saying, have I achieved my physiological outcomes? Heart rate didn't change, mean arterial pressure didn't change, cardiac index didn't change, urine output didn't change, occlusion pressure didn't change, CVP didn't change. So not only did the cardiac output did not change in 80% of the patients, none of the physiological variables for which you would want to give volume actually made a significant change in this particular group. So remember that even after all this assessment you think the patient is fluid responsive, stroke volume and cardiac output may or may not go up in a small proportion of patients, but the number of patients who are going to get a physiological response that is desired is going to be extremely small. So you need to take that account, and then you have to make sure that you incorporate that into your decision making. So summary number 3, fluid responsiveness is ARDS. I can use vena cava diameter, but remember that there is a wide cutoff and I need to be using tidal volumes that are more than 8, and I need to depend on lung compliance. Pulse pressure variation will be essentially unsuitable for most patients with ARDS. If you get a positive result, it will be useful. Negative result could be a false negative. Yes, end occlusion test and a PLR can be useful in these patients along with a tidal volume challenge, but you need to have a real-time monitoring of cardiac output, not just pulse pressure variation, and that limits us in our setting where we do not widely use PICO, LITCO or any one of those devices. And remember that even after all this, fluid responsiveness does not guarantee physiological responsiveness. You may still left with giving fluid with no changes in what the physiology of the patient is. Quickly going through RV failure, I can look at RV failure, but usually quickly in the bedside echo, transthoracic, you don't need a TEE, look for RV dilatation. RV versus LV end diastolic area more than 0.6 qualifies as RV being distended. You need to be cautious about fluid. What about extravascular lung water? We have talked about it in the morning. That's an independent predictor of outcomes, and trying to manipulate it can alter outcomes. You can't do a CT or an MRI. The tools that are regularly available for us is a lung ultrasound and thermal elution technique. Studies about lung ultrasound and extravascular lung water are essentially not very consistent. In this study, they showed good correlation between lung ultrasound and PICO measured extravascular lung water. There's a study which Ram quoted in the morning where the correlation was not good. Here the R square was 0.9 in a reasonable It's only about 20 patients, so not a big patient study. It's going to be very, very inconsistent in terms of its use. You have the single thermodilution, transpulmonary dilution techniques with either a Pico catheter or one of those Edwards catheter that you can use. If you have them, they can be an extra tool. You can look for extravascular lung water adjusted to your predicted body weight rather than in actual body weight, and see if your extravascular lung water is more than 10 ml or less than 7 ml. Less than 7 ml tells you that you probably do not have significant extravascular lung water. More than 10 ml tells you that you're probably fluid overloaded. You can also look at pulmonary vascular permeability index, and if the permeability index is more, you have much more leaky capillaries than otherwise. But most of us don't have access to these tools on a real-time basis, and that is going to be a limitation for us. There are several limitations of extravascular lung water measurement. If PEEP can interfere, lung resection can interfere, PE can interfere, so you need to be careful in terms of how you interpret. After all this is the largest study I could find, 264 patients, where they looked at PICO versus CVP guided fluid resuscitation for thoracic trauma and ARDS patients. No mortality benefit. They were able to come off ventilation, come off ICU stay faster. 70% had shock, but remember, they were all very, very young patients. They probably had a much better heart than the ARDS that you and me would see. So RV function, extravascular lung water, needs to be assessed in the bedside. When available, try to incorporate extravascular lung water and pulmonary vascular permeability index into your decision making. So putting all those together, how do I manage and optimize volume status in the ARDS? If the patient is shocky or non-shocky, if the patient is non-shocky, I have very good data in terms of fact trial, clearly telling me that conservative strategy is not harmful, gives me the same outcome, gets you off the ventilator faster, gets you off the ICU faster. So I would restrict volume, remove volume if it's allowed, and see if I can move the patient forward. On the other hand, if the patient is in shock, I would first look at the right ventricle to see if I have significant right ventricular dysfunction or acute cor pulmonale. If I have right ventricular dysfunction, remember that volume loading will make it worse, and do not give volume to these patients. These patients, I would avoid volume. I would start norepinephrine very, very early, because norepinephrine will help the right ventricular function directly by working on the ventricular interdependence and indirectly by improving coronary perfusion. Avoid spontaneous breathing if possible. Try to paralyze the patient with a short-acting paralytic. Correct your hypoxemia. This is not a patient I would do permissive hypercapnia. Try to keep your PaCO2s less. Minimize your driving pressures. Make sure you titrate your PEEP optimally. Think of proning early, because that will immediately unload the right ventricle by several mechanisms. So I would think of proning as a reason, as a treatment for shock in these patients. Consider pulmonary vasodilators like inhaled nitric oxide. If there is no RV dysfunction or acute cor pulmonale, I will look for fluid responsiveness. I will not rely on one test. I will do a couple of things, maybe a PLR, maybe an end expiratory occlusion test. If I have one of those fancy devices, then use one of those fancy devices, but never go by only one particular test. If by multimodal testing I am fluid responsive, then I am going to say whether the patient is fluid tolerant. Does he have good gas exchange? Is the compliance good? Do I have significant A line profile or a B line profile? If I have access to extravascular lung water, is it good? If all those criteria is met, then I can consider a volume challenge. If on the other hand my gas exchange is poor, my compliance is poor, I have a B line and my extravascular water is much more than 10 ml per kilo, I would probably use norepinephrine and then restrict fluids in these patients as well. In conclusion, assessment and optimizing volume status in ARDS is extremely challenging. It's going to be very, very complex. Remember that ARDS patients without shock, I would definitely suggest a restrictive fluid strategy. Remember that even if they are fluid responsive, their physiological response to volume loading is not going to be very good. So don't be volume loading them too much. If the patient is in shock, incorporate assessments of fluid responsiveness, RV function, and some form of extravascular lung water. If you have RV dysfunction, please do not give any volume to this patient. Try to use norepinephrine early and try to think of unloading the right ventricle by preventing hypoxemia, hypercapnia, and maybe thinking of proning and inhaled nitric oxide. I would do volume loading only if all these criteria are met. Patient is in shock, there is no RV dysfunction, there is fluid responsiveness based on whatever modality I check, oxygenation is good, compliance is adequate, and my extravascular lung water by either ultrasound or by one of the catheters I have shows that my lung water is not much, then it is safe for me to give volume to that particular patient. Thank you very much.